Flank pain, yes, but like cystitis or like what physical action hurts? Well, peeing hurts. Yes, okay. It hurts when they go to the bathroom. All right. Interstitial cystitis, what it ends up being is a breakdown of that protective layer in the bladder. Okay. So imagine you have these little cracks that form in the bladder, and then those little cracks allow urine to come in contact with that really tender mucosa. All right. Over the course of time, what do you think happens with that contact with the urine in the mucosa? Inflammation, ultimately, which leads to fibrosis. Okay. So yeah, okay. Not infection. That's a big one on this one. It's not infection, but I'll get to that. Good thought process there. So we have these cracks. We have this chronic inflammation leads to fibrosis. Now, what happens when the bladder expands with urine? You think? It's opening against that fibrosis. It's opening up those cracks in the mucosal layer. It's allowing more urine to come in contact. So what do you think happens as this patient's bladder expands with urine? It hurts. And what relieves their pain is going to the bathroom. So the reason I did that little song and dance is because it's the inverse story of cystitis. Does that make sense? And the reason I say that is because most, if not all, of the patients that you see with bladder pain syndrome or interstitial cystitis are going to have been misdiagnosed with numerous UTIs and given numerous antibiotics that didn't do anything for them. Okay? A lot of them will just stop coming to treatment because they're like, I don't need antibiotics anymore. This isn't working. So this is a chronic pain syndrome. All right? This is like IBS or something like that. So, unpleasant sensation perceived by the patient. 6 weeks is our timeline, right? It's been going on for more than 6 weeks. Now, last sentence. In the absence of infection or other identifiable causes. What is another word for something that doesn't have, what is another term for something that has no organic etiology? Idiopathic diagnosis of exclusion. Diagnosis of exclusion, all right? And being a diagnosis of exclusion, what does that usually mean our workup looks like before we get here? Pretty broad, right? We're excluding all the other organic etiologies to make sure that now we can reasonably say, you just have bladder pain, okay? Being that, you guys talked about IBS, right? And GI, irritable bowel syndrome, right? Other chronic pain syndromes. What is a comorbidity that goes with a lot of these chronic pain syndromes? Anxiety, depression, psychosocial issues, right? Right? Imagine, so we're going to talk a lot about, or a little bit at least in this, about not forgetting to use your consultants, not forgetting to do a holistic approach to this patient, refer them to behavioral health, right? Imagine if every time your bladder filled with urine, you were in extreme pain and you had to run to the restroom, right? Would that be conducive to travel, to work, to social situations, to going to see a movie? See what I mean? So you have to be considerate of that aspect of your patient's care and not forget that and just really hone in on the pain portion, which is what a lot of providers tend to do, all right? So, again, as I said, pelvic pain with bladder filling. As we're breaking apart all of those fibrotic areas, as we're opening up, like, you ever had dry lips before and you smile and it cracks open? Imagine that happening and then it fills with urine, all right? That's not fun. So that's why it hurts so bad. Precise etiology, not necessarily understood completely. I mean, even since I've been teaching this course, the pathophysiology and the precise etiology has been changing and changing and changing. So when I first started teaching this, when I first started practicing, it was, interstitial cystitis only. Now we have this global bladder pain syndrome title that encompasses a lot more of a left and right limit of these patients. All right, more common in women, right? And what this is what I was saying about these chronic pain syndromes, these sort of chronic diagnoses of exclusion, we really don't have a treatment, right? That's why these kind of things here and this interstitial cystitis go with a lot of psychological comorbidities. Because if you come to us, right, when you go to the provider, what are you looking for? Is it an answer / cure, right? And if you get to the point where, like, well, sorry, you're just going to have this pain for the rest of your life, it's a psychological burden, right? You know what I mean? I can't do anything to make this go away. I can try to make it better. That's all I can do. That's not the answer they're looking for. And so that really sometimes mentally affects these patients quite a bit. So again, don't forget about a holistic approach. No organic causes. Again, what do you think that means? It means we're going to have done these a lot, right? We're going to have negative urinalysis culture. What is urinary cytology looking for? Cancerous cells, urothelial, sloughing of the urothelial cells, especially in clumps, which might suggest that this is a cancer etiology, right? That's, again, another important thing to rule out is bladder cancer, because bladder cancer can be irritating. But again, we don't have any of those things. Other than the lab workup, the other things this patient's going to probably have is a cystoscopy, right? The scope into their bladder to see if there's anything in there that should be causing this pain. So this is the longer version of what I explained to begin with, right? You usually have a protective layer to keep that urine off of the mucosa of the bladder. It breaks down, you get cracks or ulcerations in it. The urine comes in contact. It becomes painful, it becomes inflamed, it becomes fibrotic. Now, every time the urine expands the bladder, it sort of breaks those apart, opens up those fissures, and it hurts. The patient feels the urgency to go to the bathroom, not because they have an urgency incontinence or an urge overactive bladder, but because they feel that pain and they want to relieve that pain. Okay, that's where the urgency comes from in these patients. All right, there's a picture of it if you like. Couple of pathologies we'll point out here. Pinpoint bleeding or glomerulation, so like basically these little cracks and fissures, little pinpoint bleeding in the bladder itself. These are seen on the scope. Or you also have Hunter ulcers. They're also called Hunter lesions, basically just big ulcerations in the wall of the bladder. But either one, you can see how those would be irritating when urine comes in contact to it, right? Okay. More so the Hunter ulcerations. So, multiple different types of patient presentation, right? What I'm talking about today is classic, right? It hurts when I have to go pee, and I go pee and I feel better. That's a classic presentation. There's multiple different layers of how this patient's going to describe that. They might describe it as a pelvic pain or fullness that goes away. They might describe it as back pain. They might not use the pain or the word pain at all. They might just describe it as pressure sensation, like it's overwhelming pressure. The word pain has a lot of different meanings for different patients, right? So just because they don't say it, you have to interpret what they're saying and understand the symptoms that they're having. Either way, what's going to be happening is whatever symptom they describe is going to be relieved by urination. Does it make sense? Okay, because what's happening in the bladder, once they relieve that, shrinks back down to normal size, kind of relieves their symptoms. Okay, so pain relieved with urination. Right? Sometimes this patient might have chronic procalgia. They might have prostatinia. They might have a lot of different chronic pains in the GU perineal area. You might describe it as low back pain, honestly. So just, you kind of have to put this. It's not as simple as this. It rarely is as simple as I'm making it now. But again, we're learning about the classic prototypical patient. A lot of times, again, you're not really sure what's going on. So this is sort of that outlier differential diagnosis that you have to rule everything else out to get to. Sorry. Okay, so certain food and drinks could be triggers. It helps to ask your patient about avoiding diarrhea, which we haven't talked about yet, but again, it's asking a patient, when you have your symptoms, write down what you've had to drink, what you had to eat. Did you lose any urine? How many times a day have you had to go? So like a diary of their voiding habits, which then would help us elicit if this may be the diagnosis or not, all right? It comes in a lot of use, especially when we get to our incontinence lecture. And then again, 6 weeks is our time threshold. So just to give you guys, we're going to talk in the incontinence lecture about overactive bladder / urge urinary incontinence, all right? There's an overlap of symptoms because both patients experience pretty extreme urinary urgency. But the difference is why. In overactive bladder, the patients realize that if they don't go to the bathroom right now, they're going to leak urine on themselves. They're going to pee on themselves, right? In our interstitial cystitis patients, they realize that I'm starting to feel that pain sensation. If I wait to go to the bathroom, it's going to hurt worse, so they have to go to the bathroom right now, right? Both are urgencies, but two different etiologies. Does that make sense? Okay. And what do you think physical exam is going to look like in a diagnosis of exclusion? Nothing, right? No physical exam findings, right? Urinary findings, clear, right? Cystoscopy findings, clear, right? No anatomic organic etiology. Okay. So, urology loves diaries, like I just said. Talked about the voiding diary. I don't put these in here because you need to memorize them. What I want you to have in your memory bank is if you get a patient that you think has interstitial cystitis, or you get an established patient who has it, remember that these exist and have them fill out what these are self-directed patient inventories, right? Symptomatic inventories. They will tell you based on a metered scale how bad their symptom is. Now that is useful, one, at diagnosis, but it's also useful at follow-up, right? If their score is high, and they come back to you after some kind of treatment and their score has gone down, that means your treatment is working. If it hasn't changed or it's gone up, that means your treatment might need to be altered a little bit. And that becomes important with these because there's really not one single magic bullet that's going to do anything that's going to help this patient. It's going to be a lot of trial and error. Okay? So anyway, this is what they look like. And again, self-directed, patient fills this out. You have this patient, they're sitting in the waiting room waiting to see you, they fill this out, and then this can go in your objective data. What this really does is communicate in a common language, subjective data in an objective fashion, right? So somebody says their pain is bad. What does that mean, right? 7 out of 10 means 100 different things to every person in this room. But this standardized scale can tell us, this is the symptom level. So that communicates not just to you, to your next provider, to the consultant, where this patient really is at, okay? Cystoscopy. We're almost done, you guys. I can see it. We're done. We're getting close. But 100 ulcerations on cystoscopy, just so you can visualize, and you can understand what it might feel like for this, these sort of stellate lesions here. And then on this side is the pinpoint bleeding, right? Again, just signs of breaks in the mucosal layer. Urine's coming in contact with that. It's becoming progressively more inflamed and fibrotic. And so it just continues on the sort of vicious cycle, okay? Differential diagnosis ruled out through either physical exam, history, or testing, of course, right? So most of our labs will get rid of that. And then, let me explain what this slide, there's no cure. Again, this diagnosis of these chronic pain syndromes can't cure them. You can hope to make them better, right? They're all going to be waxing and waning in their symptoms. And what we're looking for is to create a lower baseline, right? So this patient is going to experience fewer symptoms and less severe symptoms. That's where we want to get them to, right? So what this second bullet means, just so you understand what I was thinking, is that we used to go, this is your first line treatment. And if you fail that, you go to your second line treatment. If you fail that, you go to your third line treatment, right? We don't really do that with these patients anymore. We really don't do that a lot anymore. We just kind of fit the treatment to the patient in front of us, all right? So there's no really first, second, third, fourth, fifth line, all right? So I'm going to go over them a little bit. These are going to be used for pretty much all of our patients. Self-care, hygiene strategies, and voiding strategies. And what does that mean? If somebody has pain when their bladder fills, what could they do for themselves that would avoid their bladder filling? Pee on a regular schedule, exactly. So you tell these patients to do scheduled voiding. Go to the bathroom every 30 minutes. Even if you don't feel like you have to, that's the key. Even if you don't feel like you have to, go to the bathroom. Empty your bladder. You'll keep your pain at a lower baseline threshold, all right? We use that for overactive bladder for the same reason. You know that when you finally hit that sensation of bladder fullness, you're going to have to run to the bathroom or you're going to pee on yourself. lose urine. We don't say pee on your, Anyway, so go to the bathroom on a schedule. Reduce the instances of incontinence, all right? Heat and cold packs and holistic care, also, therapeutic, like pain modalities here are useful for these patients. Sometimes pelvic floor muscle training is useful, so a referral to a PT sometimes is useful for these patients. Okay. Behavioral health, we already discussed that, so I don't think I need to belabor that point anymore. But a lot of times the anxiety of the disease goes along to exacerbate the disease, so we can move that down to a lower baseline, and that'll help. Okay. I'm sure you guys have seen amitriptyline on a lot of chronic pain slides through your various travels throughout IPAP, right? And it's the same reason here. It has no real psychological indication as far as being a TCA. It just has indication as a chronic pain med. Why hydroxyzine and cimetidine? The best research right now is just the H2 blockade for both helps with symptoms for some reason. Okay, they are actually approved, recommended by AUA. The only one here that is a direct treatment for the damage to the glycosaminoglycan layer that will actually help regenerate it is that one, pentosan. So let's see. Intravesical DMSO acts as a antioxidant, so it helps reduce some of the inflammation. Lidocaine is pretty obvious what it does. Heparin will actually help regrow and regenerate the glycosaminoglycan layer, or at least act as sort of like a substitute for it. Remember misoprostol, Cytotec for GI? Sort of like that. Why heparin? I don't know. It just does. Okay. Procedures. Again, these are, we're going way down into the list here. They can do Botox into the bladder to help reduce with spasm. Low pressure hydrodistension, the thought behind that is to actually open it up and break open some of those fibrotic areas and inflammatory areas and then allow them to heal. That's not done quite as often anymore. Does anybody know what fulguration is? Basically just like cautery, electrocautery, okay? Or the triamcinolone lesions directly into the lesions, into the glomerulations. What's triamcinolone? It's a glucocorticoid, right? So a glucocorticoid injection. And then last result, all the way up to potentially cystoplasty or cystectomy. If it really is that bad, you can't provide any release. But that's a real last resort, okay? And again, understand that when you get to any of these type of diagnoses, it's not going to be, you have interstitial cystitis, here, do this. Thank you, doc, that feels great. I feel better for the rest of my life. They're going to come back in, it's getting worse, this didn't do anything. It's going to be an up and down. There's going to be a lot of consultants and subspecialties involved. Understand, and the reason I tell you to understand that is so you can communicate that to your patient. This is going to be sort of a work in progress. My goal is to make your symptoms as low as possible for as long as possible. But in order, I will not be able to make them completely go away most likely, so that we have a good expectation management with your patient. Okay? Any questions? Was that too fast? All right, y'all. I'll see you tomorrow, I think.